an innovator, educator, researcher, and entrepreneur. She's also the assistant director of the Stanford Biodesign Faculty Fellows Program, as well as the assistant director of the UCSF Stanford Pediatric Device Consortium, which is funded by the FDA and really is doing some innovative work within our community and for our research teams here at home. Janine, take it away.
Sounds great. Thank you guys so much for having us. It's always a pleasure to speak to the MCHRI community. It goes without saying that we are so grateful for MCHRI's support, especially because they do fund a fair number of our fellows every year. We have a fellowship. There are actually 2 biodesign fellowships. Fellowship that I took a year off of clinical work to do, and many others have, that has 12 fellows every year, and it's a fully immersive program. But we realized that didn't necessarily work for our faculty members. So this faculty fellowship is something different that I'll get into in just a couple of minutes. But they fund all the people who have a pediatric focus. So you'll hear from some of them today from different classes. But just to introduce you a little bit to what biodesign is. So we have a very clear purpose and values, but really our goals are to advance health outcomes and equity through innovation, education, translation, and policy development. But this is really firmly based in medical device development, digital health development, and those types of products, and actually understanding the process for which to get ideas translated to devices and innovations to actually get to and affect patient care. We have several values that we live by, including collaboration, diversity, empathy, innovation, integrity, and leadership. And we truly do live by these values, but we can talk more about that later. So in terms of the overall Stanford Biodesign's health technology training program, there's many different courses and many different ways to be involved. So we're specifically talking about the faculty fellowship here today, where you will need to be at least a clinical or assistant professor or above if you're on the if you're as part of the medical school. If you're part of the engineering, you can be a lecturer or above, and have the support of your department chair or division chief as well. However, there's plenty of other ways to get involved. So we have undergraduate courses and graduate courses. We have the postdoctoral fellowship that I mentioned, executive educations of people already working in industry, and various global programs from around the world, specifically countries like Japan and Singapore, India, Ireland, etc. However, we didn't have a faculty fellowship until about 8 years ago, when it started in 2014, and realized that there was really a gap in a core group of people who weren't being addressed, which is our wonderful Stanford faculty. So that includes people from the engineering school, people from the medical school, scientists, researchers, etc. And this has been a really amazing way to get people involved. But overall, for Stanford Biodesign, including those that are part of the course or the fellowship, they have started 53 companies in the last 20 years. Those companies have an impressive almost 1,500 employees. They've all raised over $1 billion collectively. But most importantly, the metric that we most live by is that we've treated over 4.3 million patients. And we've trained lots and lots of innovators. So as for the BFFs, we've trained 87 of them since 2014, including our current class. So there's a community that's really building around campus that's really exciting. And these are from all different lines, whether they're clinical educators, MCL lines, which I know isn't called MCL anymore, or the university tenure lines as well. They range from people who have just come to Stanford or people who have been here more than 20 years in their entire career. So some areas for improvement certainly could be that we're improving the number of women that are involved in this training. And as you can imagine, women are just generally underrepresented in device innovation anyhow, but we're working on that. So 25 women have gone through the program and about 10 engineers now. You can see a lot of these people here. So look for your department, see where potentially people that you know that you can chat with. If you're interested at all in the program, you can always reach out to me or my colleagues, but again, any one of these people I'm sure would be happy to speak with you. One place that's been particularly not as well represented is OBGYN. So I hope to have some more applications from that area, especially in the next year. We have a great group from pediatrics too. So a little bit about the process. So when you're trying to use technology and innovate, most of the time people come up with technology and then they figure out where the need is for that technology. But actually we do it completely opposite. So we really flip this on their head and we take the need and really start to understand what is the need. And all of my fellows will tell you that this is way harder than it sounds. Everyone thinks that this seems really easy. But the way that we go through this process is you truly understand what the need is. And then the technology comes after that. And you build the technology around that need, because you're going to be spending the next 10 years of your life at least focused on this need. So you want to make sure that it's really worth pursuing and valuable. And we emphasize design thinking. So if you've ever heard or been involved with the D School at all on campus, they have they go through a process that involves deep empathy, defining, ideating, prototyping, and testing. And as you can imagine, there's many companies, especially around the Silicon Valley, that have done this sort of user-centered design process, and some have really perfected it like Apple. However, it's one thing to have invented technology that fulfills a need, but it's a very different thing if your user is healthcare and you have the FDA and hospitals and patent agencies and insurance companies and American Medical Association, et cetera. So we've developed a process, and this was developed 20 years ago by Dr. Paul Yock and Dr. James McAhour, who's now the director of Biodesign, to deal with this complexity. We go through 3 distinct phases: the identify, invent, and implement phase, which goes on well after the fellowship. So the fellowship is really focused on the first 2. We actually have about an 8-month fellowship now for the faculty fellowship. It's completely self-directed, along with getting lots and lots of coaching and involvement, but really, it's really on the fellow to drive this. It isn't a course where you come and you listen to lectures and you kind of absorb. It really is a very hands-on process. So in October, we have kickoff sessions, and we have monthly sessions in the fall where we go through needs finding exercises. We have check-ins in November and December where all of the fellows present every single time. You have about a 6-minute presentation every month, and then moving into every week. And in the winter quarter, we focus really on the needs finding and needs screening and understanding what your need is in a very elaborate process. And then in the spring quarter, which we're moving into right now, we work more on concept generation and concept screening and a little bit of implementation planning. So understanding the IP landscape, understanding what regulatory or reimbursement or business model constraints you may have. We bring in experts from all over the med tech industry to work specifically with you on your projects. So it's a really robust, really fun fellowship, but it's also really challenging too. So there's an info session on April 6th, which we'll tell you a little bit more about. The application for next year, so starting next October, closes on April 29th. And we'll do interviews in early May. I would encourage you all, whoever's interested, to apply or to refer people out, because I know it's been life-changing for a lot of people, but it's also just a really great way to think differently about the research you're doing. You don't have to start a company out of it. It actually really just helps you start to think through problems differently too. So I'm really thrilled because we have 3 wonderful fellows from 3 different years, actually. So we have Dr. Kunj. She's an assistant professor of urology who's going to speak first. And she was in the class from 2 years ago that did half virtual. Nima Aghaepour was from the class last year who did the entire course virtually. And Dr. Meister, who will speak last, is from this year's class, who's kind of doing a hybrid approach right now, and we hope to continue to be more in person as we go on. But I'll turn it over to Dr. Kunj, Assistant Professor of Urology at Packard.
Thank you, Janine. I'm just going to share my slides here. So just as Janine was talking about, biodesign really teaches us a process. And in fact, this wasn't my primary project while I was in biodesign, but something I was working on simultaneously, and that has really taken off from the biodesign outlook and helped to create a collaborative team that we have now formed amongst myself, Dr. Gary Blumenfeld in obstetrics and fetal medicine, Enrico Danzar, a pediatric surgeon, both here and at MSK, James Wall as our mentor, and then Eric Johnson as our engineering lead for the Vortex shunt. And just to give a little bit background.
While I was pregnant with Caleb, he received 5 separate shunt placement surgeries in order to save his life. And because of the shunt, we believe that that is the reason Caleb is here today and has life. And we are really excited to hear about this new design and how it can help so many other kids just like Caleb. Hi, my name is.
So just for some background now, fetal lower urinary tract obstruction, or LUTO, it's one of the most common, most lethal fetal anomalies, and essentially occurs in about 1 in 2,000 pregnancies. And most of the morbidity is related to pulmonary and renal morbidity. The mortality rates can be as high as 80% in the severe cases, mostly due to decreased lung development, as the fetal urine that does not leave the bladder cannot fill the amniotic space and therefore affects the lubrication and development of the lungs that's normally due to swallowed amniotic fluid. And so prenatally, placements of viscoamniotic shunts were introduced in the 1980s. And the idea was that they would allow fetal urine to bypass the obstruction and allow fluid to enter the amniotic space. This increase in amniotic fluid would decrease pulmonary compression and allow for pulmonary development and survivability. However, the question remained of if there was really a true benefit from a genitourinary standpoint, if there was benefit to the bladder and a benefit to the kidneys. And so as a result, these are kind of only placed right now in the most severe cases to mitigate the risks associated with fetal surgery and intervention. The current shunts, as I mentioned, were developed about 40 years ago, and the technology is definitely older from that standpoint and has a lot of risks associated. So the most significant risks we see is with shunt dislodgement. These two shunts, the rocket shunt and the Harrison shunts, they're both made on a similar premise of using a pigtail catheter that allows the one side of the pigtail to be inside the bladder and the other side to be in the amniotic space, but they can dislodge very easily. They're difficult to see on ultrasound and require multiple placements if they are dislodged or kinked or obstructed. And each one has a significant associated risk to both the mother and to the fetus during intervention. And so looking currently at patients that survive LUTO, there's still a significant amount of healthcare costs that they incur in their lifetime. First, in the NICU, due to preterm birth and neonatal complications that amount to about $10 million in the US annually. And then the long-term renal costs, because still about 50% of patients with severe LUTO that do get shunts are having renal morbidity associated. And then about 30% of patients that don't have severe LUTO and aren't shunted prenatally also develop end-stage renal disease by adolescence. So in all, that amounts to a lifetime cost of $1.3 billion for every year of patients born in the US. So clearly, as you can see, there's a need. And based on that need, we developed the Vortex shunt to address many of the shortcomings of the currently available shunt technologies. And I'll kind of go through these one by one. Basically, first and foremost, we wanted to have an optimal delivery system that would allow for percutaneous placement of the shunt. And the current shunts, the Rocket and the Harrison, they're placed through 9 French channels, which 9 or 6 French channels, so about 2 to 3 millimeters in diameter. And with this deployment mechanism, we added an extra control so that after the shunt is placed in the bladder, the shunt doesn't immediately, the fluid doesn't immediately decompress, and it can remain in place to allow appropriate positioning of the shunt. As you can see here, this is kind of all developed in the garage of our engineer in Palo in Woodside. And this is a porcine bladder filled with fluid and inside of another cavity to represent the amniotic space. And we're placing this 7 French deployment trocar, and through that placing the shunt, as you can see here on our deployment. This is one anchor that is with nitinol and can really, you feel the tactile feedback that it's in the bladder, and that pulls against the bladder wall as you then remove the insertion trocar to allow the shunt to be in the appropriate position. Also, as you can see here, it's very echogenic and very easily visualized, which is different from the current shunts that are being used right now. The fixation and deployment is far superior, and we've seen this on our benchtop testing, where we've really tested the Harrison and the Rocket shunts to identify where the shortcoming was in the first place, and accordingly developed our Vortex shunt. And the force to dislodge it is 2.5 times higher than the Rocket shunt and about 20 times higher than the Harrison shunt. Despite this increased force required to remove the shunt, it can be consciously removed very easily by pulling towards the center part of the shunt, and that tension elongates the anchors so that they can be pulled out after the baby is born. In addition, when we were looking at the Harrison and Rocket shunts, we saw that there was no ability for the shunt to adapt as the fetus grows. And a lot of times that would lead to issues with dislodgement as well. And so our design allows for extensibility of the shunt as the fetus grows, and also is very kink resistant. As you can see here, it's bent 180 degrees and still fully patent. On the contrary, you see the Harrison and the Rocket shunts that kink very easily and thereafter won't allow drainage of fluid through the shunt. And this, lastly, I would say I'm most excited about is the additional urology perspective. The shunt that are used right now are just essentially an open tube. And so the bladder decompresses, it sits there without any urine ever filling and doesn't get the opportunity to cycle and grow as it would normally during fetal development and afterwards. And due to that, these bladders that I see postnatally as a urologist, they'll often be small and fibrotic and have high pressures, and so can't function normally even after the cause of the obstruction is treated. And so by keeping a one-way valve inserted inside of the shunt, we can allow for bladder cycling. And our initial testing has shown a threshold pressure of about 20 centimeters of water, at which point this one-way valve opens and allows the bladder to empty completely. And that mimics what we see with pediatric or neonatal voiding, where contraction pressures are pretty high, over at least 50, if not 100, when babies are voiding. And so we imagine that this will have no issues in surpassing the threshold pressures to allow for cyclical bladder empty. So with all of these benefits, we're really hopeful that our shunt will decrease a lot of the complications and the risks associated with current shunts. And long-term morbidity-wise, we're hoping to decrease renal failure costs by a substantial amount, both by decreasing the incidence of renal failure by half, and then in the remaining 50%, decreasing the onset of renal failure by at least 5 years. And with that, we see that for the 1,000 or so patients that are born every year with lower urinary tract obstruction, in the US, that would amount to about a $680 million cost savings. And looking at that cost savings, even if you take about 1% of that cost, we could charge a premium price of about $5,000, leading to a market of about 5 million per year. And looking at other opportunities for the shunt to be useful, we see that fetal lung conditions are also present, and we use currently the Harrison and the Rocket shunts in those dynamics, and so that could double our market as well. Now, for pediatrics, this is a great need, and we recognize that, you know, in the long run, as we want to expand this and bring it to patients, we have to think about the logistics of marketability and how we can grow this device so that it's sustainable. And so we've really incorporated that into both our patent strategy and our regulatory strategy, where we've included verbiage for basically our shunt can drain fluid from one luminal cavity to another. And by doing so can expand to a lot of different adult opportunities and markets. And one opportunity that we've looked at briefly is that of pancreatic pseudocysts, which also encounter similar mechanisms and are placed with minimally invasive techniques. And so that would be an early adaptation after gaining early regulatory breakthrough or HCE designation. We've been able to publish our work and gain traction from a lot of other fetal surgeons in the space. And talk to many thought leaders, both in the US and in Europe, that have been really excited about this device. And we're partnering most likely with someone in Belgium to conduct our initial fetal studies as we progress with development of the Vortex shunt. And similarly, we've looked at strategics just to think about the practicality of carrying this forward, and have started engaging in early conversations with Cook Medical to discuss potential acquisition or licensing of the technology from Stanford directly. So that being said, really, as we look at our Vortex shunt, our big risks are associated with the market size and manufacturing, which we're really focusing on right now, and securing more grant funding as well as personal donor funding to proceed. And fetal LUTO models to test our device now in fetal sheep after we've really completed the early benchtop studies. And lastly, the regulatory clearance process, which we've started early discussions with the FDA, and it seems that they're much more collaborative than in the past, and we are looking to have a pre-submission soon so that we can work through the process with them. So just wanted to kind of give you that entire kind of scope of where we've gone since this project started in 2020, actually while I was in Biodesign, and we've proceeded from there.
Thank you so much, Dr. Sheth. That's really impressive. And I think it's just a real testament to, this wasn't even your first project. Granted, you've had many since then, but this really is a repeatable process that you can continue to draw on and continue to use for future innovation as well, and really start to build a career around it, which you have clearly done, building your own lab and being such an integral part of the Pediatric Device Consortium too. So thank you so much for being here. Really appreciate it. And I'm sure you'll all have some questions for her at the end. So next, it's my pleasure to introduce Dr. Nima Aghaeepour. Technically, he's an assistant professor of anesthesiology and perioperative and pain medicine, and by courtesy, biomedical data science. But I really think of him as being part of the division of neonatology, because that's where I know him best from. And he has a wonderful project that he worked on last year and received additional grant funding for through the faculty fellowship. And I know that he's traveling right now. He's joining us for questions afterwards, but has a pre-recorded presentation, which we'll put up right now.
Hello, and thank you for the invitation. I'm going to speak about my biodesign project, which is focused on preterm birth. Preterm birth is currently the single largest cause of death in children under 5 years of age. In the past few years, my lab has worked on integrating various levels of biology, including a microbiome, proteomics and metabolomics assays, transcriptomics analysis, to understand biological pathways across these various systems that are associated with prematurity. And even though we have made some progress, particularly under David Stevenson and Gary Shaw's leadership in the Prematurity Research Center, preterm birth has remained the single largest cause of death in children, both in high income and in low income countries. For my biodesign fellowship, I used this opportunity to go back and reassess some of the assumptions that we have made about prematurity. Preterm birth is defined as gestational age under 37 weeks. And for me, as a machine learning scientist, as an outsider to medicine, I could never understand the significance of this number, 37. Turns out that this number comes from mortality rates from historic studies, often 40 years ago in Europe, and mortality rates themselves come from neonatal morbidities. This pipeline just very intuitively looked like an autoencoder that's commonly used in machine learning to me, except that 40 years ago, they didn't really have autoencoders. So again, the traditional definitions are that we have a term bucket, a preterm bucket, and an extreme preterm bucket maybe, but in reality, these buckets are very heterogeneous, and how you care for these patients very much depends on the morbidity that they have and the organ that's affected by prematurity. We can't really just go with these traditional definitions anymore. The first project that we did was to take data from CMQCC, where we had clinical information, demographic information, all the ICD-10 codes, and so on, as well as neonatal morbidities in a large cohort of patients. And we put all of these together with a simple multitask learning neural network. This already works significantly better than gestational age. This is a model built in 1 million pregnancies, tested in 10 million pregnancies. Here is how the model works. It's pretty good compared to the blue curve, which is just gestational age. This is preterm birth. This is extreme preterm birth. This is a small for gestational age. With this very simple analysis, we are already doing significantly better than gestational age. But this is not good enough because precision and recall are nowhere near the level that we would require for a precision medicine approach. This brings us to the second part of the project, where we added biology to these models. To do that, we leveraged a very unique data set that's only available in California, where we have metabolite screening data on every baby that is born in California, and it is importantly linked to neonatal outcomes. Again, this is not something that's available in any other state in the country. So we took these metabolite screening data from the newborns and we linked them to neonatal outcomes from CPQCC through a neural network. And that worked pretty well. That solved our precision and recall problem. So now we can predict these morbidities with really remarkable accuracy. Necrotizing enterocolitis, for example, is a condition that's often diagnosed several weeks after birth. It works like a time bomb. Before that, there aren't many indications. And by the time that it's diagnosed, your primary recourse at that point is a surgery with often poor outcomes. But now because we can predict it shortly after birth, there are a wide range, well, there are a range of treatments that are available to try to prevent that eventual diagnosis. The next step for us was to integrate this into Stanford's electronic health record. For this, we're building on work that Nigam Shah and others at Stanford have done to standardize our health records. We took these technologies that have already been developed and we used them to build a linkage between the children's hospital and the adult hospital. What this gave us was long-term information on the mothers before even conception, as well as long-term information on the babies. We used a long short-term memory neural network. It works just like your brain. When you read a book, you don't memorize the entire book, you only remember key concepts. Here, we are not memorizing the entire electronic health record of a mother. That's too big, but we remember key concepts that are relevant to the baby. So we have a large number of measurements on the mother, including lab values, diagnosis codes, all the medications, and so on. And we're trying to connect this to this complex web of morbidities in the babies. That turned out to work pretty well. Here is necrotizing enterocolitis. I already told you about it. We have remarkable accuracy at birth, but importantly, we can also predict it sometime before delivery. This is almost like science fiction. You can make these predictions before the baby is even born, which gives our healthcare system really valuable time that it needs to adjust to the situation and make sure the baby gets the care that it exactly needs. Similarly, bronchopulmonary dysplasia, we can make really remarkable predictions at birth, but we can also make predictions before birth. And of course, after birth, we continue to integrate with data from the intensive care unit, and we continue to learn as imaging data comes in, as hemodynamics data comes in, and so on. We got permission from one set of parents to share with you data from one patient. Every red check mark means a diagnosis that the baby actually ended up getting, and a green cross means a diagnosis that they didn't get. We are looking at time on the x-axis and prediction scores by our model on the y-axis. You can see that almost every condition that the baby got, we predicted it right, and everything that they didn't get, we predicted that right as well. And importantly, a couple of weeks before birth, we already knew what is going to happen to this baby. Even though they got diagnosed with sepsis a month after birth, we already knew that a week before birth. So this is really quite remarkable. The one place where we disagree with the physicians is IVH. And again, me being an outsider to medicine, I didn't know that IVH has grades, but it turns out that our algorithm was already automatically learning the grades of IVH without us ever explicitly asking it to do so. And there are cases where we disagree with the physicians. In the case of this particular patient, it turns out that they had a low-grade IVH that didn't lead into cerebral palsy or any kind of complications. But even though they technically got the diagnosis, our algorithm was not too worried about it. When you look at the variables that the algorithm is looking at, it's looking at a broad range of factors. For example, insulin use in the mother, antihypertensive use in the mother, even history of chemotherapy. Not many of these pregnant women are undergoing chemotherapy during pregnancy, but this is history of chemotherapy several years ago that technically doesn't affect preterm birth, but it very much affects morbidities in the baby, as well as a range of other clinical factors, diagnosis, lab values at the top. It turns out that a mother with a stronger immune system typically gives birth to babies that are protected against various morbidities, regardless of gestational age. And we are picking up on a range of social determinants of health as well. It turns out that incarceration affects the baby differently from homelessness. But we can't really just put all of these into the same buckets. Socioeconomic status and various social determinants of health have very specific effects on the babies, even if they have similar effects on preterm birth by themselves. Now, if this was for necrotizing enterocolitis, if I show you the same plot for ROP and go back and forth between them, you start seeing differences. For example, one of the differences is here. And this turns out to be vitamin B complex use, which normally you would consider safe because it doesn't affect preeclampsia or rate of prematurity. But when you start diving deeper into specific morbidities in the babies, you end up discovering concerns that normally you wouldn't have been able to see. So in the long run, we are hoping to make progress towards a place where we have our AI algorithms start before conception and then gradually start interactively working with the OB physicians and then neonatologists and then the pediatricians. It would be the same longitudinal model, and it would move with the patient as the patient moves from one part of our healthcare system to another. We are hoping to, in the long run, integrate this with various imaging and biological modalities and make it gradually more accurate. I have a long list of people to thank, including all the members of our lab, alumni, David Stevenson, Gary Shaw, and Carl Sylvester, who have been my thought partners and execution partners on these projects, various folks at the Gates Foundation, Martin Angst and Brice Godelier, as well as various funding agencies, and finally Biodesign, who gave me the opportunity to take a step back from our traditional research and rethink where these new opportunities may be. Thank you very much.
Nima, I know you can hear us, but that was just fantastic. Really exciting to see and to start to imagine where this technology and where these conclusions could potentially lead, and how we can really have an integration between our scientific and engineering colleagues and our medicine colleagues as well. So looking forward to seeing lots of future advances from your lab. Last but not least is one of our current fellows is Dr. Kara Meister. And we were so proud to chat with her today. She is a clinical assistant professor of otolaryngology and a wonderful colleague and friend. So she's going to show you what she's working on right now. Of course, these projects are all at different stages. And so she's been working on hers for the last couple of months.
Thank you, Janine. Thank you, everyone, for this warm invitation. So I am currently in the fellowship, and I wanted to spend just a little time talking to you about how I got there, because it can be intimidating to apply. So I first started with an interest in the space, and I applied in 2019 to be a clinical mentor for the undergraduate senior bioengineering course. And I was really excited, and I wasn't chosen. So I applied again in 2020, and this year I was chosen. And the students picked their project, and we worked on a tracheal stent that used electromagnetic fields to change to stenosis. And of the 4 students, 2 went on to MD programs, and one is actually pursuing a PhD in an airway engineering lab. And it's been wonderful to stay as a mentor to these students. And so with such a great experience that I applied again last year, and I wasn't chosen again. And that's okay, because if you aren't chosen, it's okay, because you can stay engaged in the program. So in 2019, I also I also did a little bit of speaking to the full fellowship, whose focus area was otolaryngology. And in 2019, I received a MCHRI grant studying a translational project looking at next generation sequencing for pathogen detection, and really found that bringing something from industry and translating that into my clinical work was exciting. And so with all of these previous experiences, I applied for the Biodesign Faculty Fellowship in 2020. And also that year became an advisor for a company called Verify, which is an AI-driven cough detection. And I applied in 2020, and I wasn't chosen. And that's okay, because I applied again last year, and I was chosen, and I'm so thankful to be sponsored by the MCHRI. So I tell you this story of failure because that is what innovating is all about. And there are a lot of ways to kind of get your feet wet or just jump right in. So my project for the fellowship is called Olive, and it's a way to bring awareness about fetal activity to parents of babies 10 weeks or older gestation in order to reassure them. And we chose 10 weeks specifically to be at the juncture between rates of miscarriage and being able to detect fetal activity. And this happens to be about the size of an olive, is how big baby is at 10 weeks. So as part of the biodesign process, you have to get really honest about what must this solution have and what might be nice to have. And as Janine said in the introduction, this is the hardest part, is really thinking about that need, shaping that need, and really making sure that this is a worthwhile pursuit. And so I give you some examples of must-have criteria. And then what for this project were our nice to have criteria. And every time this slide comes up, we joke because there's nothing about pregnancy that's comfortable. And so it's nice to have, but not a necessity. And so it's important to think about all of the stakeholders of both your problem and your proposed solution. And so as part of this process, you think about taking a step back and looking at the whole system that's operating. And so, it would be easy to focus on baby here, but we also want to think about mom and mom's anatomy. And then why are parents unsure or need reassurance? And one of the reasons is stillbirth. Well, what do we know about stillbirth? Well, could Nima's solution actually solve some of these needs? And so it's important to continue to drill down on what might be necessary or nice to have to make sure you're really addressing the problem. And we want to look obviously at what's already out there. And what we found was that the current solutions to provide parental reassurance really aren't able to be engaged in the first trimester or the early second trimester. And there are a slew of different things that can be used. But as of now, this is kind of a common area that's missing. And so part of the program you go through, well, what is the market? Who would care about this? And globally, is this a problem that is growing or not growing? And how might you position yourself, especially in the pediatric space, to make a case for funding and market opportunities? And then as part of the process, you meet with engineers and you have coaching sessions, and no idea it can be shot down. So we've thought about EEGs for these babies, and have collaborated very loosely with a local company. And then you're constantly comparing this against your need criteria. So as the process progresses, it's really that foundational construct of the need that is going to drive your project forward. Another solution that we're working through actually comes from my world in otolaryngology, which is snapshots in time to come up with a better picture. I say this in conclusion that the future state of this specific project is unknown, but this stuff to me is completely addictive, and this course will change your mindset. And so really it's that chasm between being frustrated with a clinical problem, why did these shunts keep falling out, and being able to come up with a solution that makes sense to all of the people who can get it in the hands of patients. I find it really fun, and I think doing something other than clinical medicine and traditional research really can help prevent burnout if this is something you enjoy. As Janine mentioned in the introduction, it can also be a great platform for career development, both collaboration with different schools across the School of Medicine and industry, help you build an innovation portfolio. I didn't know at the beginning that there were so many types of funding opportunities, both institutional, locally, by industry, and even a special section of the NIH. And as you work through your specialty or subspecialty groups, there are many institutional and national leadership opportunities. So I don't know where this specific project will go, but I'm grateful for the fellowship and the opportunity to look at medicine through a different lens.
Thank you so much, Kara. I really appreciated your approach, especially in the beginning, talking through what it takes to get to the fellowship, and that not every course is as direct as some others, and really appreciated your vulnerability and humility there too, because all of our fellows are absolutely fantastic, but definitely keep applying even if you've applied before, because you never know.
Yeah, I think we're so appreciative, Janine, of just all the folks that participate within our community in the biodesign course, and just want to continue to mention that you can be a part of this really interesting fellowship as it comes up. MCHRI does support a number of slots, so if you are interested, and it may come down to a conversation with your department chair or division chief. MCHRI definitely has capacity to help support you through this process, and feel free to reach out to me or through Janine if you have questions as that's coming up, and we can tell you more directly about what that is. But now just want to really dive into some questions, so feel free to post those. We did have one come through for Nima, which I can facilitate right now, which is just Nima, what are some of the commercial market prospects for the great data AI work that you're doing? And maybe how does that compare to a traditional medical device or digital health tool? So.
That's a very good question, and my apologies that I'm traveling and my camera is off mostly. But the short answer is that we don't know the answer to that yet. The FDA is still figuring that out, and they're developing the pathways around deployment of AI in healthcare settings. This is changing very rapidly as we speak. but there have been several algorithms, even algorithms that are actively learning as patients are visiting the hospitals, that have now been approved by the FDA and have already been deployed. So there is precedence there. That's exciting. Over the past year, there have been even a couple of cases that have been approved for reimbursement. So moving forward, overall, I think we are moving in the right direction, and the pathway for commercialization of these technologies is becoming more and more clear. It's not as clear as devices yet, but I think the value of these technologies has now been made clear to various stakeholders, and all the various pieces are moving in the right direction towards a place that this eventually becomes as viable as the device market.
Thanks, Nima. How exciting to just be on that, cutting edge of how the FDA is looking at changing approaches and utilizing different forms of technology to really bring improvement to care. I just want to loop in a question, which in case you missed it, Janine can give an overview on just what's expected for the Biodesign Faculty Fellowship Program. Janine, do you want to just take a second and give an overview?
Yeah, absolutely. I actually just wanted to add on to Nima's response too, because I think that, the fellowship allows you to start to think about what moats you create. You have to create barriers to entry. And so sometimes in medical devices, when you're talking about like an actual physical device, that tends to be more like intellectual property, which is IP, which we keep talking about, or, something around your regulatory pathway or your reimbursement pathway. And all of those things are really important. But when you start thinking about different digital health platforms and potentially other technologies that may come out that might be a little bit different, you may have all of those. You may still have IP and regulatory barriers to start to create barriers to entry, but you might also have other things like a business model, the first mover effect. There's other things that you start to think about, and the process helps you think through that, and your fellowship helps you start to think through that both during the fellowship and then after the fellowship. So that's something I know Nima's been thinking intensely about. In terms of time commitment and things like that, I would also say we talk a lot about companies, and we kind of talk out both sides of our mouths when we talk about biodesign, because we really talk about, we've built all these companies and we've gotten all these devices to patients, et cetera, but that's not the most important part of this particular fellowship. I find it's really valuable for faculty, not to necessarily start a company. If that's what you want to do, great. But that's just kind of a byproduct. I really think that this is a very different way of thinking about your own research, starting to come up with different ideas for your lab, if you have a lab, or starting to create a different academic niche for yourself. And truly, it's a lot of intangibles that allow you to go forward. But with that said, so time commitment for the fellowship, really come to our info session, which is in April, because there will be lots of details there, and you can look on the website as well. So it's the Stanford Biodesign website, and just look up the faculty fellowship. We can put the link in the chat for that as well. But it's about 8 to 10 hours a week, and that is from October all the way through June. So October 2022 to June 2023. And from January to June, you meet every single week from 5:30 to at least 7:30 p.m. in person or via Zoom. We're kind of alternating back and forth now on Wednesdays. And then you meet with your individual coaches during that time too. So are expected to attend all, if not the majority of those sessions. And then there's a lot of time that you do outside of work. So part of those 8 to 12 hours a week are preparing presentations, they're reading and background reading, and thinking through and researching your concept, interviewing, etc.
I will add to that you get out of it what you put into it. There are people who can do a lot less than that. There are people who spend tens of hours per week, and the results to speak for themselves.
Couldn't agree more.
Thanks, Nima. Oh, go ahead, Kara.
I was just going to say, you know, part of this is having the support of your clinical leadership, and I would add your colleagues. So I'm a surgical subspecialist. So, you know, for every time that I'm in biodesign, someone else has to either cover my call or my patients or my cases if they run over. So just it takes a little bit of pre-planning, but even those just a little bit can make it work. And it is important to be there every session.
Just make one comment as well. I think as Janine was saying, it's really about the process and like learning applications. I think more than anything, it's about networking and collaborating and getting this opportunity to meet like all the resources that we have at Stanford from outside consultants and people at the Fogarty Institute. And I mean, I would have never accessed all those people so easily and so readily. And so people are constantly ready to help. And, you know, through projects that I've done after, it's so easy to, you know, reach out and just bounce ideas off of different people at Biodesign and people that you've met like one time through all the experts that are brought into the program.
Kunj, while you're speaking, you know, how, as you're connecting with all these different individuals, how are you looking from an input perspective with your mentor, other faculty advisors, and then maybe talk a little bit about that kind of springboard moment where you decided to really embrace it and go for it. You know, curious how that decision making is happening for you.
Great question. So I think, I mean, for me, I always knew that my interest was with biodesign, and that's kind of how I came in to Stanford as well. And so, you know, I had some background in it and knew that's what I wanted to pursue. But in regards to kind of how things get moving, I mean, for example, this Vortex Shunt project kind of existed before I came here as an idea, and some initial needs finding had been done. But, you know, I don't feel like the team had really been formed, and like the right people weren't talking to each other yet. And it takes off kind of suddenly. And when things get moving and you get the right funding and the right opportunities, then like more people want to jump on and be included. And it happens very quickly. And I would say like, we've had a lot of progress just that's been faster in the last few months than I would say like in the year before that. And it's just, it's really exciting, but it's not something that can be like well predicted.
Thanks so much. Yeah, the organic nature of each project is definitely unique. But it's really awesome to see what all the work that's gone in to help form your project specifically. Janine, we just got a chat about funding support for effort, and would you mind just addressing that a little bit about, you know, kind of the points of what Kara was saying, like, you know, how past fellows have gotten their clinics covered, or you know, just that matrix of dynamics within the fellowship versus day-to-day activity.
Yeah, absolutely. So this is a real commitment, and this is a commitment because this is something that you truly want to do to launch your career. So you have to get the support of your department chair to be able to back this up, because there is a cost along with it. MCHRI provides part of the sponsorship for people associated with pediatrics, so that isn't an issue for people in pediatrics or maternal or child health. However, the time you have to find. And so we do ask you to carve out that time and that commitment. Surgeons specifically, I know, have dropped cases during this year where they drop a day of operating, you know, to their own expense, or, but they have to have the approval of their division and their department to be able to do that. So there's no protected time for this, but your division and your department should be backing you up based on this commitment, and understand the time commitment and effort allotted to this activity too.
Thanks so much. Yeah, I definitely think there's tons of value, as all our presenters have shared today, but yet a focus on engagement through the entire curriculum is really important. If there are not any other questions, we are at time. But again, I put the notice for the upcoming deadline and the faculty fellowship program in the chat. Please make sure, if you're interested, to take a look at that. And if you have any other questions for Janine or anyone else, feel free to reach out to us directly. Happy to take some time and chat with you about it. So if not, everybody, hope you have a great day, and thanks so much for your time.
Thank you so much for having us, and then also for the continued support. Really appreciate it.
Everyone.